So, to end, I wanted to introduce you to my team in Hamilton. This group of young women are the people that have been able to make me successful. I'm certainly no genius. I just simply gave them a vision that has been fed to me over the years from Dr. Armstrong, crazy ideas, crazy stuff. And they have translated it into action and has made our center very successful. These girls, my administrative assistant, Emily Bertrand, the two middle nurses are Shelley Furtado and Kristen Johnson, my clinic directors. They're fabulous. They've been with me since they graduated. Obviously, they're very young, but they're brilliant, and they are dedicated, and they're fabulous wound clinicians. And Samantha Wiltshire, on the end, she just graduated, and she has joined us. In addition, we have a fabulously gifted diabetic nurse that runs our diabetic clinic, and Sherry Kersley, and she has really transformed our ability to manage the targets for our patients to ensure that our outcomes are good, because we really can't rely on anybody else to do that. So this is my team at work, and obviously the most important team, though, is my team at home, my wife and my two beautiful daughters. I thank you so much for listening to me. I hope I haven't put too many people to sleep.
Thank you very much, Perry. That was terrific. And Dr. Bose, you're very welcome up here as well. And these two papers are open for discussion. If you wouldn't mind waving your hands or stepping up if you have any questions. Just beginning on my end, Perry, can you describe just again for everyone? Specifically, the treatment regime, how you're doing this. You mentioned that you're measuring voltages, and that almost becomes a bit like a competition for the patient. They know their number and they want to hit a better number.
Well, no, in fact, they didn't know their number. The way that it is set up, and the machine has a dial, and the technician turns up the dial on the voltages until the patient reports that they can feel it.
Right.
They don't know what the number is, and they just tell us, much like the vibration perception threshold, and that number is recorded. So there are 2 sessions in each treatment session,
right,
and each lasting about 20 minutes, and voltages are turned up. They run through the treatment. Then there's another phase, and those voltages are recorded.
Got it. And so you're treating patients now for what's the duration of the treatment now?
10 treatments. 10 days in a row. Just
10 days straight, and you haven't modified that for anyone. And you've been seeing effects out for about how long now?
6 weeks.
6 weeks.
6 weeks.
And Emmanuel,
in the trial, the beneficial effect on pain was no longer measurable after 3 months. That means 12 weeks. So probably the beneficial effect is persisting for a while between 6 and 12 weeks.
Mm-hmm. Got it.
But I have to underline that while Dr. Meyer was investigating patients with severe neuropathy, yes, those patients enrolled in the trial had mild neuropathy.
Right.
So also based on my clinical experience, the beneficial effect is longer in cases where neuropathy is more severe.
Mm.
And I suppose that, when we were thinking about, listening to Dr. Bose, that these patients with severe neuropathy are more motivated.
Right.
And so that might, I suppose, introduce a bias, although, to be honest, these patients had tried other treatment modalities, not conventional ones with medication, but they had tried other ones, and they were looking for effects in those treatment modalities and didn't get it.
Right, right. Have you had experience, either of you, with other modalities, other types of electrical stimulation, for instance? And what are the differences that you're seeing now with this more sort of controlled treatment in a box, if you will, rather than something where one has to dial up and dial down, something where the waveform is perhaps one can become more tolerant?
This is my first real foray into e-stim for treatment of neuropathy. We had dabbled with low-emitting light lasers, and we didn't really get any traction on that, and it was quite cumbersome, to be honest, to administer it, and so we didn't really get much traction on that. I don't know what your experience has been.
Yes, and if I can add a comment. Also, as underlined by Dr. Meyer, treatment of diabetic neuropathy, especially painful neuropathy, is really frustrating. And at our center, this was really the first time we had something efficacious. And so there was a lot of enthusiasm. In the past, we did a few attempts with other treatment, but really with no results.
Provisionally, have you found any kind of synergy with pharmacotherapy, or are you finding that the two are sort of mutually exclusive?
Well, the impression, I mean, these are independent. Probably the mechanisms are independent from each other. And in a variable proportion of patients, we observed a reduction of both number or dosages of analgesic drugs. But I think that since the drugs act only symptomatically, I think that this is just the reflection of the efficacy of FRAMs. But there is no synergistic effect, in my opinion.
And it's interesting that you mentioned that, David, that we were talking about there's a new initiative in Ontario where they're developing a chronic disease database,
right,
where they're going to be pooling data. I think that as FREMS gets some traction in North America, that kind of pooling of data will be helpful in determining whether there are synergies, not only with medications, but also how it works with target numbers. So does it work better with someone with an A1C of 7 or below, or not?
Well, I think I think that'll be spectacular. And again, for treatments like this, and for especially physical modalities, it strikes me that pooling data like this is really the way forward. And it may be that a technology like this could potentially upload information into a registry, and for instance, pre and post therapies, to where we can actually compare things over a large sample in a real world kind of setting. What do you think? I mean, this might be fanciful, actually, but
well, no, I don't think that is exactly what they are doing in Ontario.
Great.
And I think that's an easy thing to do as we all go to electronic medical records. It's an easy thing to do.
Right, and I mean, because I think at the end of the day, especially with all of this stuff, while the thing that we're looking for with our patients with pain is their subjective sense that they're better. That's what gives us our thrill. That's why we doctor. Ultimately, we can't manage what we can't measure, right? And so that's why we have these measurable data that you were talking about, and obviously that you were measuring in this study. And I think that's why I think these data are very, very encouraging, and they're certainly all in one direction. And looking more sort of robust studies like this, and I love the crossover design. I mean, this is really interesting stuff, and I look forward kind of to moving forward. There's a question there's oh my gosh, popping up like gosh dang. So you were first, yes, in the back.
So you're saying that your experience is that you don't use a lot of medications in the treatment of diabetic. We don't. Let me tell you that I personally don't prescribe narcotics for our diabetic neuropathic patients. They come to me with them on board, and so it's not up to me to discontinue them. That's the distinction. And you're absolutely right. Narcotics really are not an effective treatment for diabetic neuropathic pain, but they are there, and we have to deal with them.
You can leave it to me to prescribe the narcotics
I'll
for
leave
a
that.
patient,
Yes.
just as outlined. But I think anyway, I think some of the question was, these people are on polypharmacy for other
Yes.
sorts of painful conditions.
No.
such-
Sorry, the patients that we were describing were on their pain meds, whether it be pregabalin or gabapentin, or narcotics specifically for neuropathy, not for arthritis or some other chronic pain condition.
We have time for just a couple more questions, and yes, sir. So spinal cord stimulation.
In Ontario, we would certainly consider that, but to get into a pain specialist that could actually do that would take me probably 18 months, and so it becomes a non-starter, unfortunately.
Yes. Let's see. We have someone in front. Yes, in the back again. I'm sorry, I didn't hear you.
Just wondering about the expense of this without, how do you get it into wheelchair centers where you have patients that have this type of complaint,
So how does that work? You're probably not qualified to talk about this, Perry, but you have had it in your unit.
Yes, yeah. We talked to the company and Lorenz, and they would be more than happy to visit your site. And to get it.
Is the thing rented, or is it?
There are different business models. Renting is one of them. Buying is another.
Well, I'm sure that could be answered by
Yes,
far
better
more qualified
by
than we. Yes, you have the final question of the day, all the way in the back. You guys are great in the back, by the way. Superb, amazing. The acoustics must. Yes, Professor Bozzi, how is FREMS different from, say, TENS or some of the other
In our opinion, is more efficacious, so this is the big difference. In terms of physical stimulation, electrical stimulation, I demonstrated that the difference is the variability in frequency, the variability in pulse amplitude, and the very short duration of the pulse. In terms of practical terms, clinical serious clinical treatment, I mean, it's a normal transcutaneous electrotherapy, so it's not different from TENS, for instance, from the patient point of view.
Right, but the waveform is different, and theoretically this leads to less tolerance to therapy, as one might develop tolerance, say, to something like TENS. You haven't seen that happen with
No. Tolerability has always been absolutely perfect, and one of the critical point is the variability of frequency that, in a way, make the tissue remaining sensitive to this stimulation without developing resistance to the treatment. So this is the key point differentiating FREMS from TENS.
See, I didn't even phrase my question correctly, and you answered it perfectly. I don't know how that happens. This is great, and that's a wonderful way to close this session. We are right on time. You're not going to be late for the plenary session. I want to thank our two superb speakers today for this, and all of you for your great questions. Thank you very much.